a very topic which is near and dear to me, which is the principles of pediatric cardiopulmonary bypass. And we actually have two of our really outstanding perfusionists that are going to give talks, and really, we'll go with the best one first, which is Kristin Ewen, who is have been fortunate to work with her recently a lot, and is a pediatric and adult perfusionist at Indiana at IU, and does a lot of pediatrics, but has been working with us, I think, for probably almost 7 years. Is that correct?
Yeah, about, I think 6. So
Okay.
close. Yeah.
That's great. Well, it's good to have you. And then Justin Ashley is the head of director of pediatric perfusion at Montefiore. And I've had the privilege to work with you for probably, it must be almost 15 years. And he's had to put up with me and all of my nonsense, but he's an exceptional perfusionist. It's a pleasure having him as part of our team, and it's always great to see him when we go on the mission trips. So I'll let you guys take it from here. If people can mute their mics, and if you can put questions into the chat room if things come up, and then we'll address them as we go forward. Whoever's going to speak first, why don't you share your screen?
All right. Appears to be working.
Yes.
Okay.
Working well.
Yes.
All right. So, hi, everyone. It's nice to see you. My presentation today is on the principles of pediatric cardiopulmonary bypass. So this is going to kind of give an overview of what cardiopulmonary bypass is and what a perfusionist role is in the OR, because we understand that not everyone works in surgery. So this kind of gives kind of an introduction to why it's important. And then we're going to go into a little more details about a few things that were requested to go over. So the first half is going to be general information, and then the second one will kind of talk a little bit more about a few things that were requested. So like Alistair said, I work at Riley Children's Hospital in Indianapolis, which is part of Indiana University Health. So I've been there for 8 years. So we'll just get started. So all right, so some of the things we're going to cover, just the purpose of cardiopulmonary bypass, the differences in pediatric and adult perfusion. We're going to go over some main circuit components. And then the two things that we're going to go into a little more detail with is Hemoconcentrator applications and prime and blood usage in pediatrics. So why do we put patients on this big, ugly, nasty machine to begin with? So what is the purpose? So the purpose is we're going to divert blood away from the heart and lungs. This allows the surgeon to operate on a motionless heart and bloodless field. If we're doing that and the heart and lungs are no longer working, we need to circulate the blood and we need to provide oxygenation and adequate carbon dioxide elimination. With cardiac surgery, there's a lot of cooling involved. So we're going to provide systemic cooling. And then, of course, we have to rewarm the patient. And then another big component of this is myocardial protection. If the heart is not beating and it's ischemic, we need to provide protections for that heart. Sorry. All right, so looking over some differences between pediatrics and adults, we all know that pediatric patients are just not tiny adults. They do get treated differently. From a perfusionist perspective, we're going to look at some of the features that are different. Our cardiac index, we know that in peds, there's a higher oxygen demand. So we do allow for a higher cardiac index, which is usually a 1.8 to 3.0 index. Adults, we kind of keep a 1.8 to 2.4. Their blood pressure parameters are a little bit different. And then another big difference is that cardiac diagnosis affecting bypass. We have those collaterals. We have anomalous coronaries, shunts, interrupted arches, and left SVCs. Where in adults, you mostly have mostly normal anatomy. Blood product usage is a lot more frequent in pediatrics. We don't give blood a lot of times in adults. Glucose management is done. We're not so concerned with hyperglycemia in the pediatric setting, more concerned with hypoglycemia. Hypothermia, on bypass, we cool a lot more. We kind of cool for, I would say on average, probably 28 to 32 degrees for most cases. For adults, we mostly mild hypothermia. We usually cool down to only about 34 degrees for most cases. Reoperations are much more common in pediatrics than adults. So getting into circuit components, as you can see, it's a very busy, it's a very busy machine. I'm not going to talk about all the components, but we're just going to talk about some of the main ones. So starting with the first one, if you have been into the OR, this is probably one of the first things you notice is this big bucket of blood. This is called the Venus Reservoir. So this reservoir is going to be what stores the blood that's coming from the venous line, suckers, and vents. It also is going to filter it in case they have air, debris, or anything gets into the venous line. There's 2 filters in there that will filter that out. And then attached to the venous reservoir is the oxygenator, which you can see that is that circle thing that's attached to the bottom there. So the blood is going to get pumped from the reservoir into the oxygenator, so acting as like the lung. So the oxygenator is just a microporous hollow fiber membrane oxygenator. So there's a membrane between the ventilating gas and the blood. So we control the CO2 and O2. We control them with changes to the sweep gas and the FiO2 respectively. We also run anesthetic agents. We run sevoflurane or isoflurane. Inside the oxygenator is a integrated stainless steel heat exchanger, because once again, cooling and rewarming are very important parts. So from the oxygenator, just since we are talking a little bit about the heating and cooling part, I'm going to just kind of touch base on why hypothermia is an important part of cardiac surgery. So there are the benefits of hypothermia and cooling down is that, of course, it reduces the metabolic rate and oxygen requirements. So it provides against organ ischemia, and it allows, as we cool it, it's going to allow for a lower cardiac index, because they're just saying if the surgeon can't see, he can't sew. So sometimes you have a lot of collaterals. So if we cool them more, we can flow less, kind of facilitating their, they can actually see what they're doing. So of course that comes with disadvantages. There are coagulation abnormalities that come with hypothermia, and then you have to rewarm, so that increases the pump time. So how does the blood get into the reservoir? So we have that venous line, venous cannulas. So the venous cannula, there's 3 kind of main ways of draining the blood. The first one is called it's just one cannula, single stage. So you're just kind of going to be putting the cannula in the right heart. That's when the heart does not have to be open. So this is good for like things like cabbages. But in pediatrics, we open that right heart a lot. So number 2, that bicaval cannulation, that's usually what we do for pediatrics. We put 2 cannulas in. One is in the SVC and one is the IVC. This allows the surgeon to open the heart and not enter in air into our venous line. And then 3, if there is a redo operation, sometimes femoral cannulation is a good option. So if you are draining the blood, you obviously need to return the blood, and that is where the arterial line and arterial cannula come in. So the arterial cannula and arterial line, this returns the blood from the heart-lung machine back to the patient's arterial system. This is that patient's cardiac output. So our pump output is equal to the patient's cardiac output. The most common cannulation site is that we return it to the ascending aorta. If we can't do that, we can go right axillary or femorally. The cardioplegia system on the heart-lung machine is extremely important system. So this is just talking about cardioplegia. So this is a solution that we give when the heart, when there becomes a cross clamp on the aorta and the heart is no longer being perfused. So it is now ischemic. So we give a solution that is high in potassium that causes it to arrest. And there's other additives depending on what kind of cardioplegia you use. So it could be lidocaine, magnesium. But the ideal solution is just high in potassium. It's cold, uses blood as a buffer. And usually it's delivered antegrade, so just in the root down the coronaries. That's the most common in pediatrics, the way to give it. So this protects the heart when the heart is in that ischemic period with the cross clamp. And then, so the topic I'll get into a little more detail with is the hemoconcentrators. So the hemoconcentrator is basically, it's that filter that we have on the circuit. So its main job is to remove excess plasma water. And by doing this, we're going to concentrate the cellular elements and the proteins. And electrolytes and other solutes are also removed, but they're removed in equal concentrations. So the concentrations will not change in the blood. So getting into talking about that a little more, let's just talk about how a hemoconcentrator works exactly. So we have this outer shell, and then inside the shell are a bunch of microporous hollow fibers, and the blood is going to pass through those hollow fibers. So water moves across the membrane with a transmembrane pressure as its driving force. So really simply, any solids that are smaller than the pore cross the membrane, but that's going to be in equal concentrations. So the Deceiving Coefficient, that kind of tells us the ratio of plasma solute concentrate to ultrafiltrate. So how much of this gets filtered in the hemoconcentrator. So the scale is 1 to 0 for the Deceiving Coefficient. So red blood cells, platelets, they have a coefficient of 0, so none of them pass. So they get concentrated in the blood. All those electrolytes like potassium and sodium and calcium, those will have a Deceiving Coefficient, like potassium has 1. So that's free to cross through the pores. And but also keep in mind that some drugs like heparin also can pass through the hemoconcentrator, so we might have to monitor some ACTs and anticoagulation. So there are 3 main applications to a hemoconcentrator. So there's zero balanced ultrafiltration, modified ultrafiltration, and then conventional ultrafiltration. So the first one is conventional ultrafiltration, which is called CUF. And this is done during cardiopulmonary bypass. So this removes plasma water when a patient is volume overloaded. So you have to have volume in order to do this. So the main reason is to remove plasma water, which is going to increase the hematocrit and concentrate the cellular elements and proteins in the blood. So this is important with the use of Del Nido cardioplegia. That has a little more crystalloid component to it. So in order to quickly take off that crystalloid and to avoid hemodilution, we can cuff it off pretty immediately. The next application is zero balanced ultrafiltration, which is known as ZBUF. This is also done during cardiopulmonary bypass. It's important to note that this does not affect hematocrit the way CUF does. The patient is going to remain isovolemic. So basically, you have a solution and you're going to drop 100 of that solution and take off 100 of that solution. You're just going to keep doing that. So why would you do this? So there are kind of 2 main reasons why you would do this. One is you can do this during rewarming to alleviate the inflammatory response. Cytokines and things are kind of peaked at during rewarming. So if you want to kind of pull off some inflammatory mediators, you can kind of ZBUF during the rewarming process. And then the second one is to remove potassium in cases with hyperlactamia. So this is the most common, I find. The reason we do it is to help with high potassium, especially if you're giving a lot of cardioplegia, you're giving a lot of red blood cells, maybe the patient has renal issues. So what typically is done is that you will use saline because there's no potassium in that, and it's the most cost effective. So you're just basically going to be dropping saline and then hemoconcentrating volume off. And basically what this does is just dilute your potassium. You're just diluting it with this solution. And then, but if you do that, you have to monitor. There's some things you have to monitor if you're using saline. It's acidic, so you have to monitor your pH. And also, whatever solution you use, you have to watch your other electrolytes, such as sodium, chloride, magnesium, and calcium. So especially if you're giving like sodium bicarb as a buffer, that's just even more sodium that you're giving to the patient. And then the last application, all right, is modified ultrafiltration, also known as MUF. So this is done after cardiopulmonary bypass, but before reverse the heparin with protamine. So so what we do is basically is we come off pump, and then the patient we're going to concentrate the patient's blood and basically concentrate our whatever is left in the pump, our circuit. We're going to give it back to the patient concentrated. And so this way the patient gets, whatever's left in our circuit, it can go back to the patient. So it also alleviates the inflammatory response. It's going to increase the hematocrit. So today, before I muffed, the patient's hematocrit was 23. We didn't give any blood, came off, muffed, and then by the end of muff, it was 33. So it works really well for that. It also reverses an interstitial edema. It's going to concentrate your plasma proteins and fibrinogen. So it's better than sending it to cell saver because that you kind of lose all those clotting factors and things with cell saver. And allows the circuit contents to all get transfused back to the patient, and there's no blood waste. So studies have also shown that MUF has increased myocardial function, increased arterial blood pressure, increases the index, and decreases the inflammatory factors. And then the next part of this that we'll get into a little more detail is hemodilution and kind of blood product usage. So basically, the main reason we hemodilute is because of our circuit prime. There's a lot of clear fluid that potentially go to the patient that's going to hemodilute them out, especially when there's a large disparity between the patient size and like infants and neonates compared to the circuit. So priming, when we prime, we'll remove all the air from the circuit. And by removing it, we're removing it with a clear solution. So usually here we just use plasma line. So we do our best to keep our priming volumes low because we want to do our best to avoid excessive hemodilution. And then we also have to account for other, we're going to have to give drugs, heparin, mannitol, bicarb, amicar, soluble metal, albumin. That's also going to the patient, so that's also will hemodilute them a bit. So we have a formula that we can use that kind of will give us a clear picture of what this patient's hematocrit will be on pump based on our priming volumes and pre-bypass IV fluids. So at the prime volume, if we decide that if we need to give blood, we can either give a full unit or we can give half a unit. We can kind of also decide that. So if we look at an example, prime and hemodilution, just to kind of show you how what an impact, like, if you didn't give any blood in a circuit, how much it can really drop your hematocrit. Because the circuit volumes are just extremely large and compared to like just little infants. So if we looked at a 6 kilo infant who comes in with a hematocrit of 40, and we just kind of calculate their estimated blood volume and their red blood cell volume, give kind of an estimate of what our prime would be. I mean, we could wrap, it's a little hard to wrap 6 kilo infants just because they're just so little. And sometimes their blood pressure just doesn't really handle that very well. And it gives also kind of look at anesthesia fluids, and if we're giving Delnito, some of our cardioplegia volume. So our hematocrit could easily go down to 22, go from a hematocrit of 40 to 22. So that's just a conversation that we just you have with your surgeon and anesthesiologist. Where are they comfortable being on bypass and how low of a hematocrit, because you will muff at the end to increase it. And then the next, so after you kind of decide whether you're going to give blood or not, and remember, you can always get a half a unit, or you don't always have to give a full unit. That's a half is better than a whole. So also we have to decide if we're going to do FFP in the prime, because as well as decreasing your hematocrit, bypass also cause dilutional coagulopathy. So there's going to be a drop in platelet counts and coagulation factors. And with that, you're going to have an increase of perioperative bleeding and an increase in blood transfusions. So some pediatric centers use FFP in the prime to offset that dilution, especially in neonates. So this is a conversation we just started having recently in the past few months. There's probably perfusionists on there who I've reached out to ask them what their protocol is at their institution. Unfortunately, there's not like this standard, guideline of what you should do with FFP and blood usage and on cardiopulmonary bypass. So, the question I was asking people to figure out what we were going to do at Riley was adding FFP. Is that more efficient than administrating it after the dilution has already occurred? So I went back and with the cardiac anesthesiologist, and we're kind of looking at studies that show, and the studies that show conflicting results on the benefits of FFP in the prime. And then some perfusionists that I talked to were also very concerned. They've had like anecdotal evidence about it clotting off their circuit. So it kind of makes them uncomfortable, so they don't do it. So there was one study I looked at in 2020 from anesthesiology. This study was done on children weighing 7 to 15 kilos. So it was 29 patients received just plasma light in the prime, and then 30 patients received FFP. So they actually concluded that in this weight range that there was no benefit from FFP in the prime. There was no difference in postoperative bleeding or increased need of transfusion of blood products. So however, this study did not evaluate whether this can be applied to neonates, which is kind of what we were looking for. So there was a study from 2004 from Medical University of South Carolina that did look at patients less than 8 kilos. So however, it's a pretty small sample size. They just had 10 patients that received 1 unit of FFP in the prime and 10 patients that received no FFP in the prime. So they concluded the use of FFP in the pump prime significantly limited hyperlactamia, decreased the use of cryo, and decreased overall exposure to blood products. So on their Q&As, I was just kind of reaching out to kind of see what other centers do for blood usage in FFP in the prime, if you put it in your prime. For us, we usually blood prime for patients less than 6 kilos. And then for patients above 6 kilos, we calculate a post-dilutional hematocrit and then kind of figure out how much blood we want to give. And then for FFP, any patients that right now, we just started doing this probably 2 months ago, but we decided that patients less than 10 kilos get 20 mLs per kilo of FFP upon rewarming. So I'm just kind of, when we start discussing things, I'm kind of curious to hear everybody else's thoughts on what they do. And that is it.
Well, that's outstanding. Thank you very much for the overview. Why don't we, there was one question that Dave had. Was that pump your actual setup?
Oh, that was that's just a picture of the adult setup. And we do still use an external arterial line filter.
Okay.
On the adult side, not the pediatric side.
So why don't we go with to Justin next, and then we will follow up with questions. And I think I have a few, and I'm sure other people have some. But outstanding talk. But we'll leave the questions to the end. Thank you very much.
Okay, everybody see my screen and hear me okay?
Yes.
Yes.
Okay, great. Kristin, that was excellent.
Yep.
Thank you for that. And as you'll see, Kristin shared her slides with me earlier in the week, so I was able to tailor this a little bit so I don't get too redundant. Of course, in the world of perfusion, there's going to be some overlap on these topics. So the question came in to discuss a topic of lactic acidosis and how that can be controlled. I've broadened that a bit to ensuring adequate perfusion. Okay. Anyone know how I can go to my next slide?
You click on the screen
Yeah,
and then hit your arrow
up or
button.
down.
Ah,
Yeah, there you go.
should be one direction. Okay, great. Thanks, Alistair. So my plan tonight is to discuss some basic science. I'm going to talk about some other science and math that you were happy to forget about after 8th grade and will be happy to forget again by the end of the week. Talk about some evidence and some applications, and then unfortunately you may leave with more questions than are answered, but I think that's actually a good thing. So lactate, it's an organic molecule produced by most tissues in the body, mostly muscles, but it's actually produced everywhere. It's a naturally occurring substance. It's etymologically related to milk in that the root word lac in Latin means milk, and it comes to lactose is the sugar in milk, which breaks down to lactic acid by bacteria, which creates sour milk. And lactate is the conjugate base of lactic acid when the hydrogen ions break off. The normal level is 0.5 to 1.5. Most of us on the call are probably around 0.9 to 1. Primarily cleared by the liver, but 2% or so in the kidney, and the muscles, depending on activity, also cause some uptake, mostly through oxidation and actually using it again as energy. It's a product of cell metabolism without oxygen, which we'll get into that part. So glycolysis, you all remember that. So it is cell metabolism. Adenosine triphosphate, you'll recall, is the basic energy components that we need for all cells to perform their functions. There's aerobic and anaerobic glycolysis, which is with oxygen and without. Aerobic, if you recall, is the Krebs cycle, which is also a citric acid cycle. It occurs within the mitochondria, and the byproducts are actually CO2, water, and 38 ATP. Without oxygen in anaerobic glycolysis, the production is lactate and only 2 ATP. So that was interesting. I had forgotten that, if I had ever learned it, but that was interesting, 38 versus 2. And erythrocytes, or red blood cells, have no mitochondria, so only anaerobic glycolysis occurs. Hyperlactamia, which is the increase of lactate, is caused by either the increased production or decreased removal, or both. Is generally considered greater than 1.5 is an increase, of course, and moderate to severe are what we concern ourselves with, and that's greater than 3 or 5 respectively. And the causes are, of course, hypoxia and hypoperfusion, sepsis, and seizure, among others. Lactic acidosis is commonly mistaken as the same as hyperlactamia, but the component that kicks it over to acidosis is when those excess hydrogen ions overwhelm the excellent buffering system that we have in our bodies, which cause the pH to drop below 7.5. So generally, it's a lactate greater than 5 and pH less than 7.35. It's the main cause of metabolic acidosis. There are 2 types, type A, type B. Type A is the type we already talked about, which we're going to concern ourselves with, and that's when there is inadequate perfusion. And that doesn't necessarily mean that your perfusionist isn't doing a good job, because of course that doesn't happen, but it means that there's actually not the oxygen delivery to the tissues. So that as we'll moving forward, we'll see that's not just the component of flow. Type B is when there is adequate perfusion. So there are causes from various drugs and toxins or cancers, mostly in the blood. And then there's some enzyme deficiencies. And sepsis, interestingly, is both, has a component of both. It's mostly type A with inadequate perfusion to the tissues, mostly at the microvascular level, but has a component with not being able to get rid of it for some chemical component. So there is a spiral associated because the liver is affected by further acidosis. So if the pH goes below, this is from laboratory studies, but if the pH goes below 7, there's evidence that the liver will actually produce more lactate than it removes. And even though the kidney will increase its output with a lower pH, it still cannot make up for the loss in the liver. So this kind of brings it back to, you know, things that we understand a little bit. So when you're in exercise state, there's a temporary mismatch, but it's only really in your muscles. The rest of your organs are still perfused. They might actually be over adequately perfused. With the exception of maybe your gut, which any of you that run a lot would know that. But of course, your heart rate, your blood pressure, your respiration increase to counteract those effects. Mostly that's, you know, you're blowing off CO2, you're trying to correct your pH, and you're of course trying to pump more blood to those muscles where there is that mismatch. So what's happening at that local level is relatively common sense, but you know, the muscles are working too hard for the amount of blood that's going there. So of course there's more of that anaerobic action. If you have intense prolonged exertion, your lactate in your blood can actually go over 20, but it starts to drop, you know, immediately afterwards and approaches normal after 30 minutes. I read a lot going into this about lactate, of course, and it was interesting, some of the stuff. I had some misunderstandings myself, but lactate, we all view it as, you know, a poison or something negative. It's really, for us, it's just a marker, as we'll talk about more going forward. But it's also in our body, it's actually a fuel that we continually use. It's constantly being produced, and there's reuptake. And that's a lot of it's at the muscle level where it's oxidized, again, creating pyruvate, and it goes back into the cycle. But people blame lactate for that muscle fatigue. Everybody says it's, you know, lactic acidosis, and it's actually not the lactate itself. It's actually those hydrogen ions that cause the fatigue. So bringing it to our world, where the rubber meets the road, in cardiopulmonary bypass, it's simple with, if you just view it as delivery versus demand, you need to avoid a deficit. And the big thing that you need to really think about is that O2 debt. And there is a debt that we need to pay back. And what you need to do is limit that debt and pay it back as soon as possible. And the way I look at it is you need to plan for it, which is most of that stuff that Kristin just talked about. And then you need to monitor every aspect of what you're doing. And if need be, then you need to act. So oxygen delivery is essentially the content in the oxygen times the amount of flow. We view it as an index. So that's DO2I. The content is the combined component of the oxygen that's bound to the hemoglobin, but also the dissolved content. And as Kristin stated, you know, this is for peds, really 1.8 to 3 is typically what we shoot for, and adults are typical as 2.4. So we would be, you know, 1.8 to 2.4, and that is hematocrit dependent. Normal for us sitting here is about 500 milliliters per minute per meter squared. and we should consider establishing a minimum. Demand, which we think of as consumption, or VO2. VO2I is the index, and that is essentially the flow times the difference between arterial and venous content. Our normal is around 125. So if you remember what the delivery is 500. So that's 25%. So there's 75% that is in reserve typically at all times. So I wasn't supposed to jump to that. So I tried to think about an analogy for those of us that don't think about this a lot. And I tried to think in financial markets, but that doesn't really work. So I thought about Alistair's ascot drawer. And so Alistair, let's just say he has 40 to 50 ascots in a drawer, which he might have more. But so if he's taking out 2 to 3 ascots per day and not putting them back, eventually he's not going to have any ascots. And then the debt that we should talk about is Alistair's sadness that he has without having his ascots. So let's look at some evidence. So goal-directed therapy has been around for a long time, maybe 40 years or more, mostly in the realm of sepsis in ICU or the ER. It jumped over into our world, which of course we called goal-directed perfusion, and that was piloted by Ranucci. So what is that, 15 years or so? There were previous links between low hematocrit or lower flow to morbidity, mortality, and AKI. And he wanted to look at DO2, which really, if you think about what we just talked about, that's a combination of those two. So whereas one could go down, the other could be high, and you might be able to make up for it. So he found this magic number of 273 milliliters per minute per meter squared, which any of us that have considered this, which is a lot, it seems like from meetings that I've been going to, this is mostly what we're going by. This number, it might vary to some degree, but that magic number, if you fall below that, you will have, at least I shouldn't say will have, there is a connection to a greater amount of AKI and increased creatinine. The problems were that they only looked at the low value and not duration below, but how can you have a duration below if they don't have that number yet, which he established? And they only looked at severe AKI, which they used renal replacement therapy, which is pretty severe. So De Sommer took it a step forward a few years later. He incorporated VCO2, so and the index with delivered oxygen. He established that index falling below 5.4, in addition to the number he came up with, which is 262, which is pretty cool that it's about the same for DO2, that they would cause AKI anyway, at least have that relationship. And the odds ratio was 3-to-1, and that was for the Aiken stage 2. So that was useful also that he or they included more levels of AKI, and they also established a link between ICU length of stay. It's interesting to note also that Ranucci, just a year after his previous study, had looked at predictors of hyperlactamia of greater than 3. And he gave us a few more variables to think about. So CO2 production, which we've talked about, but he came up with a number of greater than 60, a respiratory quotient of greater than 1.9, and delivery to production ratio of less than 5, and those relationships to increase lactate. So there's not a lot in pediatrics for goal-directed perfusion. So it's starting to go that way. I think people are starting to think about this, but I found this was pretty interesting to me. So this was Zhang et al. They did a cohort study where they established this. It was a small group, but they established a DO2 of 353, which seems absolutely significant, like a massive number. So they're starting this trial now, and they're going to use greater than 360 as their threshold. I'm interested to see what they come up with, and I'll show you some stuff later. But this doesn't. It seems surprising. It was shocking to me. But then, if you consider the cardiac index that we talk about for peds, like upwards of 3 versus 2.2 or 2.4, then it actually makes up that difference. And also the higher crits, of course, that we have, especially in the smaller kids. So in a quick review summary for hyperlactatemia, most of us know this, but there have been links for increasing lactate with circa rest times. It kind of goes without saying. The duration of a MAP, less than 25 in neonates. Duration of CPB, I could argue, as any of us perfusionists would want to do that. Of course, if I was behind the pump, I could avoid that. But the truth is that there's a lot that we don't know or can't control at the microvascular level. So, there is a jump no matter what we do in lactate on bypass. And of course, circulatory rest, I mentioned already. Flow and average MAP seems, to make sense. Of course, this is what we do. But, the specifics of it are interesting, less than 100. I don't think many of us would allow our flows to be down that low. So it does make some sense for a prolonged period. Interestingly, for near infrared spectroscopy, most of my time using NIRS has been on the head. And there's a lot of evidence that we probably should be using it on the flank also. Like this study did a gradient, a somatic cerebral gradient, where if there was a decrease of 10%, then there was a bump of 0.6 in lactate, and that was independent of temp. But and it makes sense when you think about what they thought the cause was when you go on bypass with hemodilution, a laminar flow. There is hypotension globally in the body, and the body responds by tightening down. And you might think that everything's fine because your head sats are reading great, but you may not be perfusing adequately elsewhere. So blood bank. Most of us, I hope now, but probably not, are trying to use the newest blood possible for our small kids if you have to blood prime. But I found this interesting. They looked at the age of PRBCs, greater than 5 days or less than 5 days, just that simple. And in the CPB prime, it was 2.5 versus 1.6, the lactate level. And at the end of CPB, it was 5.4 to 2.7. So what I found interesting about this is, because I've always washed my blood. I know not everyone does that, but I've washed my pack cells before putting it in the prime for kids, which will help a lot. But if you look at these numbers, that will not help you in the long run if it's old blood. It'll help you to some degree, but those red blood cells are hindered in their capabilities. At least this shows it too. So we take a team approach. As Kristin said, we try and have a conversation with surgery, anesthesia, perfusion, come up with a plan, flow, pressure, temp, crit, pre-op volume. We have to, keep an eye on anesthesia, the post-dilutional crit, which Kristin mentioned, Hemoconcentrator, muff. What is our plan? Cannulation strategy, how are we going to do this? And our perfusion plan, I broke it down by delivery and demand. So going back to what we talked about, this comes down to blood flow and oxygen carrying. And of course, if you have your oxygen on, then that component is covered. The demand is the metabolic state, which is all of that range of ages, sizes of children, up to adults, widely varying degree. And then the temperature. So we try and use a prescriptive design with our circuits. You need to have a large enough circuit for your blood flow. So this is specifically for blood flow. So you have to have a large enough circuit to do that. We do the calculations, of course, for our blood flow. So you need your oxygenator flow. The oxygenator itself has to be big enough for that flow. The venous return has to be adequate. That's not only the cannula, but also the venous size, the venous line size, the diameter. Are you going to use vacuum? The arterial line pressure, the arterial line has to be big enough. And arterial cannula, of course. So, I mean, at one point I was using 5, maybe 6 actually at one point, different circuits for different size kids, and scaled that back considerably. But when you're trying to be that prescriptive to try and do everything for a child, these are the components. Every single one of them have to be considered. The crit, we're not all the same. The procedures, right? That you could have a 3 kilo kid, single ventricle, you might need a crit of 35, or coming off 40, 45. Whereas most procedures up to all the way through adults, you'd be fine with mid 20s, 30. But these are the components you need to talk about. So what is the crit? What's the dilution going to be? Are you going to use autologous prime, which many people don't even approach it seems, with peds, but a lot of kids, you can use it. So there's some topics that Kristin had covered. There is a difference between whole blood and packed red blood cells, how you're going to approach that, depending on what you have in your institution. Do you have to treat it beforehand? With heparin, of course, with whole blood. FFP with size consideration, like Kristin mentioned, I've always used, I've used 3 and 5, depending on the institution I was at, but I think it's reasonable. So that was interesting what she pointed out. Hemoconcentration, of course, the anticoagulation strategy. If you're talking about adequacy of perfusion, it's interesting. When I started thinking about all aspects, everything comes into play, everything we do. So this, anticoagulation plays a large role so you can limit bleeding, so you don't spiral later. We have to monitor all of these parameters. This is our job, is to watch out and protect these patients from, everything that the surgeon and anesthesiologist have done to them. DO2, VO2, those are the kind of the new ones that we're talking about. Lactate, of course, that's why we're here talking about this. I think it's imperative to monitor lactate. My understanding is, the last meeting I attended that talked about it was 50% of the people did not monitor it still. And NIRS is, as we talked about. And then to the ACT part. So, I don't need to go through all of this, but if there's a need to intervene, you have to do it. As a perfusionist, I'm speaking to perfusionists now, this is your role as an advocate for that patient, and communicate. That's our job. So that's what I will talk about in this part, is say there's some need that you need to communicate with the surgeon. NIRS is pointed out here as one of them, as being positional, maybe, or we have to talk to anesthesia about the head position, or the cannula position, so we can get adequate drainage. All of these things play a large role in what we can do, and being quiet doesn't help anyone. It's interesting to point out that I always think this is funny. We can get, it's a nice compliment, I should say, from that the surgeons think that we can change the laws of physics, but as you know, we cannot. So there's only so much that we can do, admittedly. So if you need to ask the surgeon to, take a second to address the needs, then do so. I know it's a challenge. You have to use these tools if you have access to them. So flow sensors, I think, are imperative. Some say with a roller head, you may not need them. It shows you the flow right there. It's never wrong, but I beg to differ. So if you have flow sensors in the correct position, it makes everything easier and safer. You in the correct position, you won't have to worry about shunts. It's easy with shunts open, you can easily forget about 500 cc's per minute going through the shunts that you think that you're flowing forward, and that's considerable when the full flow on your pump says 1.2 to a child. And also it just makes it easier for and safer for the settings on the roller head. Your occlusion settings you can trust, and also the software in there, with for the tubing size, it has to be set for that, as you know. So inline blood gas monitoring, we use a CDI 550. I love it. I think you kind of need to have it as far as safety goes, especially moving forward. Now with our capability of monitoring continuous DO2, that's right on there, real time. You can see how long you're below the threshold as soon as you set those for your institution. Point of care testing, I love. You get faster results right there in the OR. The NIRS, we already talked about how important that is. Heater coolers even, for adequacy of perfusion. Yeah, I think it is. So you really need to have temp probes that are accurate. Those heater coolers should be maintained, calibrated regularly. But the temp probes are important, for pre and post pump, venous and arterial, for that, warming or cooling gradient, and also to make sure that you're not overcooking the brain. And then an EMR, electronic record, especially if you have connection to the pump, and real-time connection to anesthesia machine even. A lot of these available now are, they provide, queryable results. You can see right after the pump how many minutes you spent, below whatever threshold you set. Everything helps for safety and ease. So speaking of tools, so this is just an example of an app. These are screenshots from my phone. There are multiple ones of these out there. This is simple. You just plug in the size information and the volume information. It populates these numbers for you, post-dilutional crit, even with ANH, cup 1 or 2 units. And then also it creates this right, the next screen, it's 1, 2, 3. Those are 3 screens. And then it gives you all this information. So this was, of course, an adult. And you can see, if your crit is, let's say 26, we hope it's about that high, you think 2.4, right? That's full flow for an adult. So if you're there, that's great. But, many times that your surgeon's asking you to drop the flow, I can't see, like Kristin mentioned. So you're down to 1.8 or 2, and you're below that threshold. But this gives you that information. So at least you have the ammo. I will caution you that these are not, at least from what I found, not tailored for peds. So I plugged these in, this is a 55 centimeter, 3 kilo kid with a crit of 42. So, it makes sense. You got your post-dilutional as 18, so you're going to need blood. It doesn't have the capability of putting in the blood, which might be a next iteration. But here's the thing. So you drop down to the DO2 graph, and nothing on here is going to make sense except the fact that, maybe with this new knowledge that we have, because this is again, is populated for that 260 to 280, that 270 range. But it does make sense if you look at that, say 2.8, right? We flow 2.8 for a 5 kilo kid with a crit of 26. You're around that range that they were talking about. So it all makes sense. This is something we'll be able to use more moving forward. This is something that, the DO2 calculator is also on this app. So at any time, you can plug in, the size, the flow, the crit, and it will, and the PO2, and it will give you that. So if any of you see the perfusionists behind the pump on their phone, they're not on Facebook. They're calculating DO2 continuously. And this is something we use. So this is a pretty simple thing to create. This is an Excel spreadsheet. I say simple. This would take me too long to do. So we had to call in the big guns, the youngsters that grew up with electronics. But you can tailor this to your institution. This is specifically for adults. So you plug in the patient information and everything populates for you. including what we added just a couple years ago is this, the DO2 graph. So similar to what we just looked at, and it's based on 273, like I had said, that's in the bottom right. This just makes everything easier. It's very useful. So we have this also for pediatrics without the DO2 part, but it just has a lot more information. Cannulas and hemoconcentrators, and there are also just more circuits. So these can be tailored for your own institution, like I said. But if you want, just let me know. And if you don't have one, I could easily send this to you, and you could find somebody that's about 24 years old or so, and they could tailor it for you. So in summary, you need to avoid the cause. And when we're talking about, the lactic acidosis, it's too late. If you get to that point, then you kind of miss the boat. You do everything you can to come out of it, but that debt is already there, that oxygen debt. So you try and avoid the cause. You have to then mitigate the effects of what you can't control. And that would be, the circa rest time, right? Cross clamp time, CPB, the flow, everything you can. If you have to communicate, that's a big part. So, right, I just said communicate, use those tools. If everything you have available to you, and fight for more. If you don't have it, it's all for monitoring and safety. And then education is imperative. So, go to meetings, local or okay. I found that not to have the greatest content, but national or even international if you can, and read the publications. There's always more and more that's coming out that we can consider, which actually brings me to this. That's exactly why these sort of things are great. It gets us talking and thinking. And thank you. You'll see in the bottom left is my email there, if anybody needs anything. Thank you.
Welcome. That was outstanding. And there a couple people in the chat, Betsy and Alexi, would like you to send them that spreadsheet.
Okay.
And Alexi's email is in the chat.
That would
Okay,
be
great.
Betsy Jr.
Yeah.
My chickens don't need perfusion right now. They're okay.
Yeah. One other question that came up for you, Kristin, is what rate of bicarb administered during Z-buff?
So we typically just give, put 25 milliequivalents per 500 ml of saline, and we use saline. So that's only for, if you're using a different solution, I don't have the answer, but.
And then, again, I'm a big blood conservation guy, low circuit size, and decreased hemodilution. And so to me, combining the two talks, which were both excellent, one of the things is what you do to mitigate inflammation. And then the aspect of that is reducing the blood exposure and also circuit size, reducing circuit size. And so what are the things that can be done to improve, a better understanding of how those things interact and how they affect your flows? Because I'm a low flow guy also. So any strategies?
So I'll take it first, and then Kristin can correct me on everything I said wrong. But so you touched on some of them. So a smaller circuit size is ideal. Coating, surface coatings also. I like to limit the amount of Hemoconcentrator that I use if possible. And in fact, try not to use it at all if you can. It's much more difficult, like Kristin said, with kids. First of all, there's a lot of evidence that muff works well. And also with Del Nido nowadays being 1 to 4, and especially for short bypass runs, you kind of have to kick it on right away. I don't know what else, Kristin.
No, I agree. I think that making just little, I think all these little changes you make in a circuit just add up. Whether you're making your venous line, arterial line as short as possible, on your boots as short as possible, getting rid of the arterial line filter. And I agree with Alex, or Alistair, I'm sorry, that with the full flow of 2.2 is what he used for a cardiac index. And I'm actually quite comfortable with that in a pediatric setting. We do that, just having exposure to Alistair's preferences a lot on mission trips has kind of like changed. It's like, oh yeah, this is actually okay, not having to flow like a 2.6 on a pediatric patient. I can, use 2.2. You can use a smaller circuit. And I think just kind of getting more comfortable with pushing circuits a little bit more also. Yeah, I think I mean just kind of make as many changes as you can to a circuit just to make them smaller, less foreign surface exposure to the patient is also excellent. So if anybody else has any other tidbits on what they do at their center, we'd love to hear it.
And Alfred just came to tell me that I have 16 ascots.
Great. So you ran out of them pretty fast then.
Yeah, I did.
So I think in a non-mission setting, running our reservoirs higher will help. But when you go to mission, which I remember setting up one of Alice's cases, and he walked in the room and he says, "How are we going to drain the patient?" I'm like, "Oh yeah, we don't have suction. There's no vacuum assist here." So in a setting that's non-mission, which is here, some people even have mass mounted, where and in your suction lines is something that we don't think about, but in small babies, just those suction lines take a lot of volume just to fill. So you stick that in the well, and you're taking all our volume from our reservoir by the time it gets back to us. So that's some of the things that we don't think about. So you can shorten or make them 3/16 as opposed to 1/4-inch suckers. I think those things help as well.
I agree with that. But one other thing that you didn't touch on, which is related, that has come up a lot from people on these trips, and especially with COVID in these countries, is ECMO and the conversion of a cardiopulmonary bypass and the difference between an open and a closed system. If either of you could touch upon that for people to understand. And then how can they, in a third world country, take a bypass circuit and make it a closed system to be an ECMO circuit?
So if you just use, well, first of all, to kind of put those two things together, there's a difference, with the anticoagulation need for open versus closed. I've always used open, but I know some places with closed circuits, can run ACTs, down 300 or even lower, whereas we're of course at 480 or so. It's the air contact that that does cause that need anyway. As far as changing to or using a bypass machine for ECMO, it depends on what kind of head you have. If it's a roller head, there are some concerns there with safety. You need to have the safety devices in place that can actually control the pump if there's a negative pressure on the venous side, or otherwise you can create more harm. Last time I used roller heads for ECMO, we used a bladder on the venous line, a capacitor, so to speak, which could pretty easily be created. If you do have access to a centrifugal pump, then it's as simple as a line in and out. That's basically what our ECMO is anyway. Kristin, you have anything to add to that?
We actually have a hybrid pump that it's an ECMO circuit that it's a centrifugal pump, but we use it for our lung transplants, and so it can be used as a ECMO circuit. And then if something happens and the surgeon needs to go on full bypass, we can quickly manipulate a few clamps and go on full bypass from that. And like you were saying, the big reason we do that is a heparinization. We don't have to heparinize as much as supporting the patient. But I think that my concern on a mission trip would be the roller head not being able to monitor negative pressure. I think that would concern me, but it's not. I mean, really, you're just kind of doing everything similar, except you're just getting rid of that reservoir, and you don't have to pepperize as much. But
Great. Alexi has a question, or he's got his hand up.
Yeah. Well, thank you so much to Kristin and Justin. It's been really great having you tonight for me. As Kristin know, I don't have very big experience in kids. I've been most an adult perfusionist. And I recently, back in 2019, I started doing some kids cases. And I think I started working in a center that is like 2,300 meters above the sea level. And I have been having all kinds of experience working there because it's been really difficult for me to control lactic acid. I started thinking that I may have some low hematocrit. I need to increase that. And then I started using blood bank, and I don't have a way to watch my red blood cells in the center I'm working in Cuenca, which is the city I'm working on. And I don't know, I start increasing the flow, and that helps a little bit, but not a lot, not as I expected. I run like 50 pumps in that center, and I still having the same issue, one over and over. And I've been using like one thing is that our surgeon do all the cases at normothermia. I mean, he wants all the kids who have 35 or more for all the kids. And that's one problem. I think sometimes it will help if I could cool a little bit the kids. I don't know if you have any idea, any clue, if you see something I could improve. I will really appreciate your comments.
so, Alexi, do you, when you give blood, is it like in the prime? Because you said you can't wash it.
Yes,
so.
yes.
So, I mean, so you have a
Yes,
hemoconcentrator?
mainly in the prime.
Okay. Do you have a hemoconcentrator? I assume?
Yes,
Okay. I would suggest
yes, of course.
debufing that blood before you go on bypass. Just washing it up with some, and then I try, like when I go on mission trips, it's kind of nice. If we are priming with blood, I usually do gas on that blood before we go on, make sure the K is adequate. And it will help if you Z-buff before you go on bypass. And that is a way you're washing that, kind of cleaning that blood up.
I prime with blood, and I try to do a gas measure before going on pump, and try to compensate all the disorders. But the lactic acid is just head even with blood banks. We don't use blood bank more than 5 or 6 days for kids. But I didn't have the idea to Hemoconcentrator. It's a good tip. Thank you.
So just a couple of things. What are you said you're trying to get the crit up. What are the crit usually, on pump?
Doing my lowest hematocrit I'm using?
Yeah, well, yeah, or average or.
Well, I try starting not letting all the kids go lower than 20. And then I start to increase into 30. So I try the kids not to fall beyond 30. That's what I'm doing right now. And I try to increase the flow. And that's what I'm trying to do more often. I don't know if you have any clue, but I start doing on 20.
Yeah, there's so many variables. We should talk. I would be willing to, go through it with a couple people that I work with too. We can talk on the phone or by email. But I would think, there's so many variables. Some of the stuff I touched on, I would question, potentially is the flow accurate that you have, that you would want to make sure of that. I'm sure you're watching all of that anyway. But the pressure, you've covered the crit. You could potentially try and tune those kids up before bypass too. Giving the blood to them before bypass is essentially washing it too, if you have time. Yeah, I don't know. There's so many variables. That's a tough one. I've never pumped that high. I don't know. That's an interesting challenge.
Yes, and I was trying to look from some articles and something to give me a clue, and there are not too many published on that high, so I couldn't find any guides. It's different. It's completely different. I mean, I've been ventilating my oxygenator above 90% of oxygen. Otherwise, I can get a good PO2. So, and that was new for me because I never used 90% of oxygen for at sea level. So.
And what's your venous sat usually? Do you have a venous sat?
Not continuously. We don't have a continuous monitor. I mean, an inline monitor. I have to run AVGs frequently. So I try to keep it around 70, and sometimes it came out with 80, sometimes it came lower, but it's around 70. I try to keep it around 70. Another thing we found is that our anesthesiologist likes to use vasopressors a lot. So we talked to her, and she tried to stop that a little bit, because I usually go on pump with lactic around 1.5, maybe 2. At the beginning of the pump. That was my first AVG. So we tried to talk to her about that. There are too many things we need to improve, but the thing I was worried most was the continued increasing with the pump, with the lactic acid. It started increasing since the start and never stops.
What's your prime volume?
Oh, it depends on the kid and the oxygenator, but we try to keep it as low as possible. I mean, like 300, maybe 400 if we are running a kid of, I don't know, 7, 8 kilos. We have the RX50 sorting kids 100, 101. Those are the oxygenators we use more often. And for bigger kids, we have the Inspire 6F.
Yeah, I think one thing that's critical, and I think Kristin talked about it, was which is washing your blood, and the technique that she just prescribed using the Z-buff on the blood is a vital thing to do. And it's the age of the blood is critical. And we have had patients that they have given us blood that is very old, and I've seen patients that blood was pushed and the potassium was over 10 and the patient arrested. And so wow. But it's also not just the age. And the interesting thing is the study that Justin showed with the age greater or less than 5 days. The reason is the red blood cells are very fragile. And so you get lysis of those red blood cells, which increases your lactate. And so that's why washing out those cells is critical.
Okay. Thank you, Alistair.
Doesn't do as good of a job, but it's better than nothing.
Yeah, okay. Thank you so much, Alistair.
You're welcome. Well, it's running late. This was a great session. Great job, Kristin and Justin. It was outstanding. Great talks. And thank you very much for everybody who participated.
Thank you.
Kristin, Justin, and everyone, thank you. It was great seeing all of you.
And one last thing, if everybody can keep Mickey Wilder in our thoughts and prayers. Her husband passed away last week from massive MI. But, she's one of the people who've been involved with heart care for the last over 20 years and is always a delight to see. And it's just such a great member of our community.
Thank you, Alistair.
You're welcome.
And we'll be back on March 18th, so please mark your calendars.
Great. Have a great day, everybody. It's great seeing everybody. Bye.
Bye. Thank you.
Bye.